2025 concise clinical guidance regarding ACC expert concession statement on the evaluation and management of cardiogenic shock. So cardiogenic shock is a complex heterogeneous multifactorial syndrome in which cardiac disorder resulting in insufficient cardiac output culminating in end organ hypoperfusion. It is one of the most common cause of admission to contemporary cardiac intensive care unit and remain a highly morbid and lethal complication given its dynamic and often unpredictable course, with short-term mortality ranging from 30% to 40% and 1-year mortality approaching or exceeding 50%. Cardiogenic shock due to acute MI has been the most extensively studied form of cardiogenic shock in randomized controlled trial. The incidence and prevalence of cardiogenic shock due to non-acute MI causes specifically like heart failure related cardiogenic shock has increased during the past decade, with notable difference in baseline characteristic, comorbidities, resource utilization and in-hospital outcome. Despite advance in revascularization and increasing the use of temporary mechanical circulatory support during the past 2 decades, RCT have largely failed to identify treatment strategy that reliably improve mortality other than early revascularization for acute MI cardiogenic shock. The first trial to demonstrate any benefit with temporary mechanical circulatory support was the Danish-German cardiogenic shock trial, which showed that early use of a microaxial flow pump in selected patients with ST segment elevated MI related shock improved 180-day survival as compared with standard of care. Yes, sir. So cardiogenic shock is a disorder that results in both clinical and biochemical evidence of sustained tissue hypoperfusion irrespective of underlying blood pressure. Acute MI defined as the irreversible necrosis of heart muscle due to myocardial ischemia. It mostly common occur due to the infarction, due to deprivation in myocardial oxygen supply, due to interruption of blood flow in coronary artery because of plaque rupture, erosion, fissure or coronary dissection. The data element set for myocardial infarction event require both subjective and objective findings including symptoms, cardiac biomarkers and ECG abnormality. So cardiogenic shock in acute myocardial infarction due to acute MI in the presence or absence of ST segment elevation on 12-lead ECG. So it may be either due to ST elevation or non-ST elevation MI. Consistent with the Shock Academic Research Consortium standardized definition, left, right or biventricular dysfunction may result from ongoing MI, ischemic injury or mechanical complication of MI as the primary etiology of cardiogenic shock. Cardiogenic shock resulting from acute bradyarrhythmia, tachyarrhythmia or advanced heart block, post-cardiac arrest or any other complication in the setting of acute MI are also classified as acute MI cardiogenic shock. Second cause, most common cause is the heart failure, which is defined as the universal definition of heart failure symptoms and or sign of heart failure caused by structural or functional cardiac abnormality and one of the following: elevated natriuretic peptide or objective evidence of cardiogenic pulmonary or systemic congestion. Heart failure cardiogenic shock due to cardiogenic shock related to primary myocardial dysfunction ascribed to either ischemic or non-ischemic etiology of cardiomyopathy. It may be further categorized into the de novo heart failure cardiogenic shock or acute on chronic heart failure cardiogenic shock, which include acute decompensated of chronic or progressive heart failure with dilated cardiomyopathy. As with acute MI cardiogenic shock, there may be varying degree of ventricular involvement including left, right or biventricular congestive profile in heart failure cardiogenic shock. It may be further categorized by specific etiology of the underlying myocardial dysfunction like acute myocarditis, Takotsubo cardiomyopathy, peripartum cardiomyopathy, tachycardia related cardiomyopathy, hypertrophic cardiomyopathy or infiltrative disease such as cardiac amyloidosis or sarcoidosis. So whenever patient comes with cardiogenic shock, so first we have to initially evaluate within 30 minutes. ACC has also given acronym like SUSPECT, which shows that first we have to see the symptoms or sign: urine output, sustained hypotension, perfusion, ECG or echocardiogram, status of congestion, and then we have to try either to higher level of care or to cardiac catheter laboratory in case of acute MI or critical care cardiac ICU. Then to higher level of care we have to transfer if there are no facility available to early revascularization or advanced support for the cardiogenic shock. So after initial evaluation we have to manage the shock in which we have to start initially with the pharmacological drugs, that if and we have to reassess frequently to need of any advanced treatment needed or not. Then we have to stabilize the patient by serial reassessment of shock trajectory, and then we have to decide whether need of escalation or reconfiguration of any temporary mechanical circulatory support or not. If then we have to optimize the therapy to achieve the decongestion, metabolic and hemodynamic targets. Personalized intervention like coronary revascularization, structural intervention or any ablation is needed or not. Then we have to assess for the exit strategy, either native heart recovery or heart replacement therapy from the temporary mechanical support. Then palliative care engagement for refractory shock with limited therapeutic option. So this is based on the SCA staging, which is Shock Society for Coronary Angiography and Intervention.
LSC and RFC mandatory છે?
ના
એનો level of recommendation કેટલું છે?
Sir, cardiac catheter level in case of only MI or ischemia is acute present.
આપણે તો કરતા નથી ને? તો કે આનો level of આટલું પહેલું આટલું ક્લિયર લખ્યું છે તો ક્લાસ 1 recommendation છે, level of evidence છે.
ક્લાસ એ મેન્શન નથી કરેલું છે એમાં. Clinical scenario depend, then only we have to go for the angiography.
પણ આપણે તો કોદી નથી કરતા, almost ક્યારે નથી.
So initial evaluation start with early diagnosis of cardiogenic shock. It is critical importance and timely intervention may ultimately impact outcomes. For purpose of research and enrollment in clinical trial and registry, the criteria used to diagnose cardiogenic shock had included hypotension and organ hypoperfusion along with evidence of congestion or decreased cardiac output, which is measured by the pulmonary artery catheter. To aid clinician in confirming the suspicion of cardiogenic shock, the writing committee proposed the mnemonic suspect CS, the component of which include the minimum necessary criteria needed to make an early diagnosis of cardiogenic shock. So, first, symptoms or signs like altered mental status, confusion, chest pain or pressure, cold and clammy extremity, rapid pulse, low pulse pressure, less than 20% of 25% of systolic blood pressure, elevated JVP, crackles, orthopnea, PND, lower extremity edema. Then urine output, oliguria or anuria, urine output less than 30 ml per hour or less than 0.5 ml per kg per hour. Then sustained hypotension, systolic blood pressure less than 90 mmHg, mean arterial pressure less than 65 mmHg for more than 30 minutes, or a more than 30 mmHg decrease from the baseline, or the need of pharmacological or mechanical support to maintain the systolic blood pressure more than 90 mmHg. Perfusion evaluate marker of end organ malperfusion including lactic acid level more than 2 millimole per liter, ALT level more than 200 unit per liter or more than 3 times the upper limit of normal, creatinine 2 times upper limit of normal, pH less than 7.2, metabolic acidosis without another non-cause. Then ECG or echocardiogram non-invasive measurement to evaluate acute ischemia including ECG and sonographic evidence of ST elevation, MI, regional wall motion abnormality, evidence of LV or RV dilatation and systolic dysfunction or any valvular pathology. Then congestion, presence or absence of congestion based on physical signs and hemodynamic illustration of ventricular involvement, either left ventricle, right ventricular, biventricular involvement. Then trials, appropriate trials or shock team activation or possible transfer to a higher level of care.
Most of the criteria, will take 1 hour to decide.
Yes.
Most of the criteria. What is the immediately you come to know that this patient required, patient is in cardiogenic shock and will require, whatever next step.
જેમ કે સેકન્ડ હતું તે યુરિન આઉટપુટ ઓલિગુરિયા ઓર એન્યુરિયા એટ ધ એન્ડ ઓફ 30 મિનિટ્સ તો તમે
That will take one hour to decide. ये ECG अरे ECG માં infarct doesn't suggest a cardiogenic shock है, बराबर? Congestion doesn't suggest a cardiogenic shock है, you know? પછી આ perfusion irrigation will take હવે તો lactic acid કે બધું કરવું હશે it will take some time.
યુરિન આઉટપુટ તમે આવે એટલે કેવી રીતે પહેલા યુરિન આઉટપુટ મેઝર
Once sustained hypotension, you require blood pressure to monitor for at least half an hour, 1 hour to decide કે ભાઈ આ immediately patient આવ્યું છે, how did you decide કે આ patient ને cardiogenic shock છે અને એને actively કશું કરવું? Another criteria will take 1 hour to decide.
Symptoms and signs initially which are
કોઈ પણ patient restless, mental confusion, restless, persistently restless અને cold and clammy body. Perspiring and cold and cold and clammy body, very steady pulse and mental confusion and restless. So persistent restlessness and confusion હોય so you suggest કે આના organ
એ ક્રાઇટેરિયા પણ પ્રેક્ટિકલી કોઈ જગ્યાએ બેસતો
they
નથી
are just to
થિયોરેટિકલ
So
બધા
most important here is, see, almost all shock will have cold and clammy pulse, probably irritability and this. But most important is you are having hypotension and orthopnea, send patient to get or cardiac arrest. Simple. Orthopnea is the key. તમારું બ્લડ પ્રેશર ઓછું અને પેશન્ટ શાંતિથી સૂતું હોય તો કાર્ડિયોજેનિક શોક હોવાની શક્યતા બહુ નહીવત ક્લિનિકલી થઈ જાય. રાઈટ, સો ઓર્થોપ્નિયા ઇઝ ધ કી.
મોટા ભાગે શાંતિથી સૂતું હોય ને તો
સેપ્ટિક શોક કોઈ પણ કાર્ડિયક પેશન્ટ શાંતિથી સૂતું હોય either he is having bilateral failure હતો તોય શાંતિથી સૂઈ શકે પણ પેલો જે રેસ્ટલેસનેસ કન્ફ્યુઝન ને પેલું થ્રેડી પલ્સ ને ઓલ્ડ એક્ટિવિટીઝ હશે ને
કોલ્ડ એક્ટિવિટીઝ સર ઓલમોસ્ટ બધા શોકમાં હશે પ્લસ પેલું હાઇપરડાયનેમિક હોય સેપ્ટિક વાળું અધરવાઇઝ બટ ઓર્થોપ્નિયા ઇઝ ધ કી.
So diagnosis begins with suspicion of underlying state of inadequate cardiac output in patient at risk. This can be confirmed using readily obtainable clinical, laboratory or imaging data. Regardless of the location of hospitalized patient and across all hospitals with varying resource infrastructure, clinical symptoms, physical examination and vital signs form the cornerstone for the initial diagnosis of cardiogenic shock. So physical findings like lethargy, confusion, altered mental status, cold sweaty extremity, prolonged capillary refill time and reduced urine output even in the absence of hypotension should similarly raise consideration of cardiogenic shock.
આ સૌથી અગત્યનું છે ફિઝિકલ એક્ઝામ.
And simultaneous assessment of respiratory status may yield additional sign of congestive or
the prolonged capillary refill time.
that we have to pinch on the finger and then we have to see how rapidly turn up speed from back. Like presence of hypotension defined as systolic blood pressure less than 90 mmHg or mean arterial pressure less than 60 or more than 30 mmHg drop from baseline for more than 30 minutes, heart rate of more than 100 beats per minute and narrow pulse pressure in isolation or in combination should all raise suspicion of a cardiogenic shock. Now other more subtle symptoms like nausea, vomiting, abdominal pain, early satiety, decreased appetite reflect the evidence of GI ischemia due to inadequate cardiac output. Then clinician suspicion of cardiogenic shock should be supplemented by readily available laboratory tests, comprehensive metabolic profile assessing for acute kidney and hepatic injury, venous for arterial blood gas with evidence of metabolic acidosis and elevated venous for arterial lactate level. Additional laboratory data useful in overall evaluation of patient with cardiogenic shock include serum sodium and biomarker including high sensitivity troponin, anti-proBNP. Central venous catheter can be helpful to measure CVP and obtain central venous oxygen saturation. So every patient suspected to be in cardiogenic shock should have 12-lead ECG and if available transthoracic echo or point of care cardiac performed by experienced clinician. ECG evidence of acute ischemia, particularly ST segment elevation, should lead to early trial to the cardiac catheterization laboratory, either locally or at the nearest capable facility, and revascularization as approach to coronary anatomy. Sonographic evidence of diminished RV or LV systolic function, cardiac tamponade, or acute valvulopathy should prompt a timely consult to a general or interventional cardiologist or cardiac surgeon or advanced heart failure cardiologist as appropriate. It is important that initial suspicion and diagnosis of cardiogenic shock does not require invasive hemodynamic. However, it is useful in illustrating the ventricular involvement and congestive profile of the cardiogenic shock patient and may inform therapeutic decision making. So, guidance doesn't suggest that you have to always require the invasive hemodynamic to diagnose the cardiogenic shock, but it helps in the decision making regarding the further treatment. Once the diagnosis and severity of cardiogenic shock have been established, invasive monitoring or diagnostic procedures such as arterial line and pulmonary arterial catheter may be used to continuously monitor hemodynamic to aid in selection of and response to treatment strategy to address the congestion and perfusion. And depending upon the available resource at the hospital where the initial diagnosis is made, transfer to higher level of care is needed to further stabilization or further action of the management. So, transferring the patient of cardiogenic shock to the higher facility. Acuity and complexity of cardiogenic shock patient require an interdisciplinary, collaborative and standardized team-based approach to the management. Most hospitals in US can provide the acute cardiovascular care. Some can serve as cardiogenic shock center, known as level 1 cardiogenic shock hospital center, being equipped with the full gamut of on-site 24/7 medical and surgical expertise, temporary mechanical circulatory support device, and high procedural volume. In many cases, such center may also provide advanced heart failure therapy such as durable LV assist device and orthotropic heart transplant. So these are the level which are defined from level 1 to level 3. So level 1 is the higher most center, which include all the cardiac care, cath laboratory, cardiac ICU, with advanced facility of durable LV assisted device and heart transplant facility with temporary mechanical circulatory support device. Then level 2, which are included in STEMI and PCI capable center with temporary mechanical circulatory support option, but they have not advanced facility like LV assisted device, long durable and heart transplant capability. Level 3 center are capable of initial diagnosis of cardiogenic shock, but they are not included in PCI or temporary mechanical circulatory support capable institute. They have intensive care unit and on-site specialty like general cardiology consultation is available at the level 3. So observational studies of patient transfer to dedicated cardiogenic shock center have shown mixed result with respect to associated mortality for the transferred cohort. Multi-center retrospective observation analysis showed higher associated mortality among transferred patients that was driven by heart failure related CS. In a separate study comparing acute MI cardiogenic shock and heart failure cardiogenic shock, patient presenting initially to level 2 or 3 cardiogenic shock hospital center or a level 1 cardiogenic shock hospital center in a dedicated regionalized network across multiple hospital systems encompassing 3 states, the author found comparable short-term outcome and similar rate of bleeding, vascular and stroke complication. So 30-day mortality and short-term outcome were similar in level 2 or level 3 comparing to the level 1 hospital center. Now the predictor of outcome among patient transfer for management of cardiogenic shock vary based on the etiology of cardiogenic shock. In heart failure cardiogenic shock patient, older age, mechanical ventilation, renal replacement therapy and multiple vasoactive drugs were associated with worse outcome, while use of pulmonary artery catheter was associated with favorable outcome. On the other hand, acute MI cardiogenic shock patient, overweight size, BMI more than 28 kg per meter square, worsening renal failure, lactate more than 3 mg per deciliter, and increasing the number of vasoactive agents were associated with higher mortality rate, while use of any temporary mechanical circulatory support device was associated with beneficial outcome. Now the CS team activation, as cardiogenic shock is the hyperdynamic evolving state, it requires standardized interdisciplinary and team-based approach for the management. There are several single center protocol initially established the proof of concept with associated lower in hospital mortality. Multi-center observation analysis among 10 of 24 centers with shock team showed that shock team centers were more likely to obtain invasive hemodynamic, use of advanced type of temporary mechanical circulatory support, and have lower risk adjusted cardiac intensive care unit mortality. Exact composition has varied across institutes. Key stakeholders from the following specialty have typically been included in the team: critical care cardiology, general critical care in collaboration with cardiac intensive care unit cardiologist, advanced heart failure and transplant cardiology, intervention cardiology, and cardiac surgery. Now, the key consideration which helpful for triage, potential transfer, appropriate risk stratification, and treatment of cardiogenic shock patient. So, first is the SCAI stage, which categorize the patient into different 4 stages. Then, does the patient need or require escalation of temporary mechanical circulatory support at this time? Third, is there any absolute contraindication to escalation of treatment, like do not resuscitate order has been issued by the relative, or any terminal illness is present in the patient? Does the institute have the resource to support this patient anticipated needs, like intensive care unit bed availability, clinical expertise, and TNCS resources and availability? Is the patient hemodynamically stable for transfer? So these 5 points are helpful for the triage and transfer of the patient. So this is the SCI shock stage, which divide into the total A, B, C, D, and E, total 5 stages. So stage A consists of not currently experiencing signs or symptoms of cardiogenic shock, but they are at risk for its development, like acute myocardial infarction, myocarditis, or any cardiomyopathy, in which physical examination includes JVP normal, perfusion is well and warm, distal pulses are strong, mentation is normal, lung sound are clear. Biochemical marker in which lactate and renal function are normal, and hemodynamically patient has systolic blood pressure more than 100 mmHg, cardiac index is more or equal to 2.5, CVP is less or equal to 10, pulmonary capillary wedge pressure is less than 50, and pulmonary artery saturation is more or equal than 65%. Stage 2 include the clinical evidence is there that patient has hemodynamical instability or hypoperfusion, like JVP clinical examination raised JVP, but perfusion is well and warm, distal pulse are strong, mentation is normal, and lung sound on lung examination there are crepidation. On biochemical marker, there will be minimal renal acute kidney injury, while lactate level will be normal, and brain natriuretic BNP level will be elevated, with hemodynamic is suggesting of cardiogenic shock, like systolic blood pressure, mean arterial pressure are less than the expected, and heart rate is more than 100 beats per minute. Stage C consists of hypoperfusion requiring intervention, like pharmacological or mechanical beyond volume resuscitation, in which there will be clinical sign of JVP elevated, mental status will be altered, pulse will be cold and clammy, lung examination will show crepitation, and urine output will be less than 30 ml per hour. Also biochemical marker will be raised, lactate, creatinine, LFT, and BNP level. And hemodynamic will also altered, with cardiac index will be less than 2.2. Stage D consists of failure of initial support strategy to restore the perfusion, like pharmacological or mechanical support, in which there will be physical examination will suggest stage C plus worsening signs of JVP, mental status, distal pulse, and lung sound, and signs and symptoms of hypoperfusion despite initial therapy. Then biochemical marker in which lactate level, renal function, LFT, and BNP will be raised. And hemodynamically, it will require accelerating dose or increasing number of pressure, vasopressor, or addition of temporary mechanical circulatory support device to maintain the perfusion. And stage E consists of acute or impeding circulatory collapse, in which clinical sign will be deteriorating with unconscious mental state, near pulselessness, and cardiac collapse with multiple defibrillation, lactate level more or equal 8. Patient will require CPR, and severe acidosis will be there. And patient will have profound hypotension despite maximal hemodynamic support, and will require bolus doses of vasopressin. So these are the 5 stages depending upon SCI shock stage. So there is utility.
You say vasopressor.
Uh,
Vasopressors, which vasopressor will you use and how long will you wait till you predict that now further assistance is required?
and that is clinical decision only, and they suggest that support should be minimum dose and shortest duration as possible. They have not.
What duration will you wait before you will conclude? કે હવે તો મિકેનિકલ આ જે ડિવાઇસની જરૂર છે કે ઇમ્પેલાની જરૂર છે કે આઈબીપીની જરૂર છે?
That they have not mentioned any specific duration.
કેટલું અવેલેબલ છે તમારી પાસે?
IABP is most available. Pilani, कोई rare case में.
Vasopressors are usually use different vasopressors over a short period of time. Single vasopressor, short duration of time. ધારો કે non-adrenaline value for half an hour, BP doesn't increase. The BP use vasopressor. એવું લખેલું છે?
ના એવું નથી, પણ મલ્ટિપલ વાઝોપ્રેશર કેન બી સિંગલ એવું નથી.
અને એને મેં પીરિયડ તો નક્કી કરવો પડશે ને કે આટલા પીરિયડ વેઇટ કરીશ.
2 hours, 3 hours.
ડ્યુરેશન એ મેન્શન કે આર્ટિકલમાં.
કારણ કે 1 કલાક પછી તો ખબર પડશે કે યુરિન આઉટપુટ 30 ml થી નીચે આવી રહ્યો, 30 ml થી ઓછો આવ્યો. 1 કલાક તો બધું નક્કી કરતા જ થશે. મોમેન્ટ પેશન્ટ કમ્સ, હાઇપરટેન્શન છે, ઓબ્વિયસલી યુ આર ગોઈંગ ટુ સ્ટાર્ટ તો કે ઇન્ક્યુબેટ કરશો કે તમે યુ આર ગોઈંગ ટુ સ્ટાર્ટ વાઝોપ્રેશર. 1 કલાક તો ફક્ત યુરિન આઉટ ઓછો આવે છે એ નક્કી કરતા થશે.
Mostly this study are done on the acute MI, so there are chance that if we support the temporary mechanism support with patient hypotension and cardiogenic shock, they will recover. So most study are done on that patient only.
મયુર નથી આવ્યો? મયુર બધું મયુરના પહેલામાં આવે સિલેબસ.
આ શક્ય નથી.
આ બધું એટલા માટે કે સંપન્ન પેશન્ટ કમ્સ ટુ થાય કે આ 3 કલાકથી આનો પ્રયત્ન કરે છે. અમને તો ફોન જ આવે રિલેટિવનો કે 3 કલાકથી આ કરે છે, બ્લડ પ્રેશર ઊંચો આવતો નથી, પેશન્ટની ઇમ્પ્રુવમેન્ટ જ નથી. હવે
એટલે પ્રેક્ટિકલ નથી આ બધું, થિયોરેટિકલ લખીએ છે બધું, પણ આ બધું રિયાલિટીમાં
આ ક્વેશ્ચન છે એટલે how will you wait before you કારણ કે તમારે એટલે સાઇન યુ ટુ કે એક્ટિવેટ આ જે બધી આ પ્રોસિજર કરવા વાળી ટીમને એક્ટિવેટ કરવી પડે. એને એક્ટિવેટ કરતા પાછા 1.5-2 કલાક થઈ જાય. ફરી તમારી પાસે ઇમ્પેલા છે કે નહીં, આઈએબીપી તો હોય પણ ઇમ્પેલા છે કે નહીં, મેડમ ઇમ્પેલા વાળા સારું કહો તો આગળ. એટલે આ ક્વેશ્ચન છે.
Usually, see, if you start non-adrenaline drip, you wait for 1 hour. If the blood pressure doesn't increase, systolic, you add dopamine. Then you wait for 1 hour, and then it doesn't increase, blood pressure doesn't increase. Then you take a decision whether the patient should be transferred or for
શું છે વિસ્તાર તમારો કંઈ?
Initial golden 1 hour. In that period we have to evaluate and we have to make decision whether patient require any higher transfer or not. So in 1 hour they have initially mentioned we have to evaluate all the parameters there, and then we have to make decision. So invasive hemodynamic, there is utility in applying invasive hemodynamic to characterize the phenotype of cardiogenic shock, assess the severity of shock, and guide temporary mechanical support, circulatory support, related acceleration or winning decision in the cardiac intensive care unit. Now, ESCAPE trial, in which evaluation study of congestive heart failure and pulmonary artery catheterization effectiveness in severe symptomatic and recurrent heart failure patient without cardiogenic shock, do not apply to the contemporary cardiogenic shock patient population. So there is no definitive data.
આવ્યો તો મયુરને યાદ કરો.
તમે 100 વર્ષના થવાના છો. હવે અમારો પ્રશ્ન એવો હતો
હવે 1 કલાક થઈ ગયો છે, કાર્ડિયોજેનિક શોકમાંથી બહાર નહીં આવ્યું, હવે શું કરશો?
કાર્ડિયોજેનિક શોકનું પેશન્ટ આવ્યું છે, તમે વાઝોપ્રેશર શરૂ કરે, how will you wait or how many vasopressor you will give,
use.
how long will you give, and then you will decide કે IABP ની જરૂર છે, એમ્પેલાની જરૂર છે કે એક્મોની જરૂર છે, એ કેટલો પીરિયડ હે.
તો એ પ્રોબેબલી 5 થી 7 દિવસમાં રિવર્સિબલ થશે. એવા બધા પેશન્ટમાં વી ડાયરેક્ટલી ડોન્ટ જમ્પ ટુ ધીસ IVP or MCS or ECMO something directly. અને ઇનિશિયલી કાર્ડિયોજેનિક શોકની ટ્રીટમેન્ટ જ એ છે કે whatever is the etiology we need to correct that. હવે એક્યુટ માયોકાર્ડિયલ ઇન્ફાર્ક્શન છે તો રિવાસ્ક્યુલારાઇઝેશન ઇઝ ધ મોસ્ટ primary cornerstone of the therapy. You will give a bridge therapy કે તમે revascularization achieve કરો, and then after achieving the revascularization you wait for the this how the patient responds. Primary cornerstone is the treat the etiology cardiogenic shock rather than going all these inotrope
એટલે પેશન્ટ મિકેનિકલ વેન્ટિલેટર પર છે, વાઝો પ્રેશર પર છે, એને કેથેટરમાં લઈ જવાનું.
હા
અને
તમે રિવાસ્ક્યુલારાઇઝેશન કે કોઝ
કેથેટરમાં તમે ઓપન કરો ને તો એ ડેફિનેટલી એનું
હા
symptoms
એટલે
પણ
કોઝ ટ્રીટ કરવો પડે. કોઝ ટ્રીટ કરાવવા ગમે તેટલું IVP MICS કંઈ બી કરશો તો નહીં મળે.
ચલો નોન ઇસ્કેમિક કાર્ડિયોજેનિક શોકમાં
નોન ઇસ્કેમિક કાર્ડિયોજેનિક શોક તો મોસ્ટલી જે આ બધા ટોક્સિન ઇન્ડ્યુસ જે હોય છે
DCM છે, નોન કેશ DCM છે અને એમાં એક્યુટ ડિકોમ્પેન્સેશન થયું. તો તમારો ક્વેશ્ચન એવો છે કે તમે કેટલા ટાઈમ સુધી વાઝો પ્રેશર આપશો અને કેટલા ટાઈમ સુધી બાકીનો મિકેનિકલ માટે વેઇટ કરશો.
મિકેનિકલ તો સર એવું છે કે લગભગ કોઈ બી મિકેનિકલ ડિવાઇસ છે એ કોઈ બી જગ્યાએ ક્લાસ 1 ઇન્ડિકેશન તો છે કોઈ બી કાર્ડિયોજેનિક શોકમાં. કોઈ બી ઇવન IVP ઇઝ નોટ ક્લાસ 1 ઇન્ડિકેશન. એટલે ઇનિશિયલ જે વાઝોપ્રેશર ચોઇસ છે એ નોએડ્રેનાલિન છે અને ડોલ્બુટામિન છે, અને સેકન્ડરી દેર ઇઝ અ મિગ્રેનોન જે હવે થોડી ઘણી જગ્યાએ યુઝ થાય છે. બધાનો એન્ડ ટાર્ગેટ એવું જ કહે છે કે વી નીડ ટુ ટાર્ગેટ ધ બેઝિક એક લેવલ ઓફ મેપ કે મીન આર્ટેરિયલ પ્રેશર આપણે અચીવ કરવાની ટ્રાય કરવાની. અને
હવે ત્રણેય ચાલતા હોય 2 કલાકથી ઓપ્ટિમમ ડોઝમાં અને સમહાઉ બ્લડ પ્રેશર ના આવતું હોય, યુરિન ના આવતું હોય તો
પછી આપણે કોરસ આલ્વેઝ થેરાપી મિકેનિકલ જે છે એના ઉપર મૂકીને
એના માટે મૂકવા માટે કેટલો વેઇટ કરવાનો ટાઈમ કાંઈ છે?
ના એવો ટાઈમ ખ્યાલ નથી એક્ઝેક્ટ.
ધેટ્સ ઓલ ક્લિનિકલ જજમેન્ટ.
હા એક્ઝેક્ટલી ટાઈમ મને ક્યાંય એવો ખ્યાલ નથી. પછી કદાચ આપણે કોઈ એટલું પ્રેક્ટિસ નથી કરતા પણ પછી આ બધું મૂકીને પછી એને લગભગ પેલા ટ્રાન્સપ્લાન્ટ લિસ્ટમાં એ પેશન્ટને મૂકતા હોય છે મોટે ભાગે બધી IM ઇન્સ્ટિટ્યૂટમાં. ત્યાં આવું પેશન્ટ હોય તો આપણે બ્રિજ થેરાપી તરીકે આ બધી ડિવાઇસ મૂકીને એને ટ્રાન્સપ્લાન્ટ લિસ્ટમાં મૂકીએ પેશન્ટ.
ઓકે, હવે થોડો ટાઈમ આપણે કાર્ડિયોજેનિક શોક બોલી દઈએ. સેપ્ટિક શોક હોય અને વાઝો પ્રેશરથી રિસ્પોન્ડ ના થતો હોય તો કેટલા ટાઈમ માટે તમે વેઇટ કરો? 4 કલાક, 2 કલાક મિકેનિકલ સપોર્ટ આપો?
ના, સેપ્ટિક શોકમાં તો કોઈ મિકેનિકલ સપોર્ટની કોઈ ઇન્ડિકેશન જ
ઇકમો વગેરેની જરૂર ના પડી શકે.
કોઈ બી મતલબ એ બધું મૂકી શકાય પણ એ કોઈ બી પ્રૂવન થેરાપી નથી. સેપ્ટિક શોક તમને લાગતું હોય અને એને તમારે ટ્રીટ કરવું હોય તો યુ ટ્રીટ ધ સેપ્સિસ અને જે સોર્સ હોય એ ટ્રીટ કરો અને મીનવાઇલ એ રિસ્પોન્ડ અને બાકી ઓર્ગન સપોર્ટ આપો. એટલે કે સીઆરઆઈટી આપણે બહુ ઓછું યુઝ થાય છે પણ તમે સીઆરઆઈટી જો એટલું યુઝ કરીએ પ્રોપરલી તો એ વાઝો પ્રેશર બી ઓછા થતા જાય છે અને પેશન્ટની બોડીને રિકવરીનો બી ટાઈમ
બાકી સ્લેડ આપવાનું.
હા સીઆરઆઈટી છે, સ્લેડ બી કરી શકાય 12 કલાકનું. હમણાંથી હવે બધા લોકો સીઆરઆઈટી અવેલેબલ નથી ત્યાં 12 કલાકનું સ્લેડ કરે છે. 12 કલાક સ્લેડ કરે 1 કલાક ગેપ આપે પછી પાછું 12 કલાકનું સ્લેડ કરે એટલે કન્ટિન્યુઅસ સ્લેડ બી ચાલતું હોય. ધેટ ઇઝ ઓલ્સો વન ઓપ્શન. પણ સેપ્સિસમાં કોઈ સર્ક્યુલેટરી ડિવાઇસ બહુ હેલ્પ નહીં કરે. એ તમારે કોઝ જ અને સેપ્સિસ જ ટ્રીટ કરવું પડશે કે તમે કદાચ સોર્સ રિમૂવલ માટે કોઈ આપણી પાસે એવું પેશન્ટ હોય કોઈ જગ્યાએ એબ્સિસ છે, કોઈ જગ્યાએ ડ્રેન છે, થાઈમાં કોઈ એવી વસ્તુ છે જે આપણે ડ્રેન નથી કરી શક્યા અને એટલો ટાઈમ બાય કરવા માટે આપણે કંઈ કરી શકીએ પણ મિકેનિકલ ડિવાઇસ વિલ નોટ હેલ્પ ઇન સેપ્સિસ.
કોઈ બી માયોકાર્ડાઇટિસ, ડેન્ગ્યુ કે ગમે તે એની અંદર સ્ટીરોઇડ નો
સર બધી સ્ટડીઝ તો ના જ પાડે છે. ઓલમોસ્ટ એવરી સ્ટડીઝમાં ડેન્ગ્યુમાં તો બહુ જ એક્સટેન્સિવલી સ્ટીરોઇડ્સ માટે રિસર્ચ થયું છે. દરેક જગ્યાએ ના જ પાડી છે કે ઇટ ઇઝ નોટ બેનિફિટેડ.
રૂમેટિક માયોકાર્ડાઇટિસ એસ્પિરિન અને સ્ટીરોઇડ.
એસ્પિરિન કોલ્ચિસિન બી આપતા હોય છે, પછી આ ઇન્ડોમિથાસિન બી આપતા હોય છે. એનસેડ્સ ઇઝ
એસ્પિરિન અને સ્ટીરોઇડ રોમેટિક પહેલા અત્યારે હવે ખબર નહીં આવે આપતા
પણ મોટા ભાગે
એકાદ શોટ તો આપી શકાય.
રિવાસ્ક્યુલાઇઝેશન અને પેઇન્ટિંગ ઇથિયોલોજી બાકી બધું તો જગલી ઉપર નીચે કર્યા રાખશે પણ મેની પડે.
The use of pulmonary artery catheter is associated with improved outcome and complete hemodynamic profiling as compared with incomplete or no hemodynamic assessment has been associated with lower in-hospital mortality, and early hemodynamic assessment within the first 12 hours has been associated with improved clinical outcome. Now, hemodynamics enable the bedside clinician to illustrate the congestion profile, LV dominant, RV dominant or biventricular shock, which have been associated with adverse outcome in both acute MI and heart failure related cardiogenic shock. LV dominant congestion is often characterized by elevated pulmonary capillary wedge pressure or LV and diastolic pressure more than 15 mmHg. In contrast, RV dominant congestion is accompanied by relatively normal pulmonary capillary wedge pressure in the setting of elevated right atrial pressure more than 15 CVP more than 15 mmHg. Biventricular congestive profile suggests elevation in both right atrial and pulmonary capillary wedge pressure. Both biventricular and RV congestion profiles are common in cardiogenic shock patients and have been associated with adverse outcome including death and the need for durable LV assisted device and heart transplant in the multi-center observation registry. Hemodynamic parameters associated with adverse mortality and cardiogenic shock include low mean arterial pressure, elevated right atrial pressure, elevated right atrial pressure to pulmonary capillary wedge pressure ratio, which is more than 0.6 mmHg, and reduced pulmonary artery pulsatility index, which is the ratio of difference between the pulmonary artery systolic pressure and diastolic pressure divided by the CVP. So, pulmonary artery pulsatility index that reflect an amalgam of factors including RV contractility, RV pulsatile load and RV congestion is almost useful in the setting of an elevated right atrial pressure more than 10 mmHg and in the absence of moderate or severe pulmonary hypertension. Criteria for low pulmonary artery pulsatility index value differ between the acute MI cardiogenic shock in which it is less than 0.9 mmHg and heart failure patient undergoing LV assisted device implantation in which value is less than 1.85 mmHg is the lower value. Writing committee suggests that integrating invasive hemodynamic assessment with non-invasive cardiac imaging like echo, point of care ultrasound whenever available to more precisely characterize the phenotype of cardiogenic shock patient. Then pharmacological management. The goal of pharmacological therapy is to slide.
જાણવા જેવું હવે જ આવ્યું છે ચાલુ રાખીએ.
The goal of pharmacological therapy is to mitigate congestion, optimize cardiac output and enhance perfusion to vital organs. Whenever a congestive phenotype exists, it should be addressed through intravenous loop diuretic, augmentation with thiazide diuretic and renal replacement therapy for ultrafiltration if congestion is refractory to medical management. Failure to address congestion may lead to microcirculatory ischemia and damage to multiple organs including the kidney, liver and GI tract. In this regard, the transrenal perfusion pressure may serve as useful conceptual model that represent the difference between the mean arterial pressure and the central venous pressure.
Transrenal pressure તમે કેવી રીતે ડિટેક્ટ કરશો? ટ્રાન્સરેનલ પરફ્યુઝન કેવી રીતે ડિટેક્ટ કરશો? The useful conceptual model. How will you determine transrenal perfusion?
એટલે જ મેં લખ્યું છે જે થાતું નથી એ બધું ચર્ચામાં જ છે.
ચર્ચામાં
મેપ્સ ઓફ એમ એટલે કદાચ અમુક લોકો રિસર્ચ લેવલે કરતા હતા.
એટલે બેઝિકલી આ ટર્મિનોલોજીમાં એટલે કેવી રીતે નક્કી કરે છે પણ જવા દો આગળ. હવે તમે વાંચી લાવો ટ્રાન્સરેનલ પરફ્યુઝન કેવી રીતે ડિટેક્ટ કરે છે?
Hypoperfusion can be addressed by starting IV vasoactive medication including inotrop, chronotrop, inopressure, inodilator, vasodilators and vasopressor. These drugs are commonly used in clinical practice for the management of cardiogenic shock, but some are been associated with increased adverse effects including arrhythmias and increased myocardial oxygen consumption. So committee suggests that they should be used in cardiogenic shock at the lowest possible dose to support the adequate perfusion and for the shortest possible duration. Inotrope enhance the cardiac function by increasing the load-independent contractility of the myocardium. More specifically, cardiac calcitrope, including catecholamines and phosphodiesterase 3 inhibitor, increase the concentration of intracellular calcium to augment the contractility. These agents exert their myocardial force through direct action as opposed to secondary effect on chronotropy and vascular tone. Chronotrope, on the other hand, increase cardiac output by predominantly increasing the heart rate. Inopressor like dopamine, norepinephrine and epinephrine increase the cardiac output with increasing systemic vascular resistance. Inodilator like milrinone or dobutamine increase the cardiac output and reduce the afterload through systemic vasodilation. Vasodilator decrease the preload and afterload through reduction in systemic vascular resistance, augmenting the cardiac output. Vasopressor increase the mean arterial pressure by increasing the systemic vascular resistance. So the balance should be maintained between the alpha and beta adrenergic receptor activity that determine the predominant effect of catecholamine, which runs the gamut from pure inotrope to pure vasopressor. There is no clear concern regarding the choice of first-line vasoactive agent. Committee agrees that norepinephrine is a reasonable first choice for most patients with cardiogenic shock who are hypotensive. Level 2 and 3 cardiogenic shock hospital centers should pursue consultation and consider potential transfer to a level 1 hospital center when patients are refractory to the initial pharmacological therapy for consideration of temporary mechanical circulatory support and advanced therapy. So temporary mechanical circulatory support devices in cardiogenic shock focus on the ST elevation MI cardiogenic shock and have been limited by the sample size, study design, patient selection, timing and other key limitations. They are being increasingly utilized in the treatment of both acute MI and heart failure related cardiogenic shock. Routine use in all cardiogenic patients is strongly discouraged. IABP2 trial was a multi-center randomized open label trial which suggests that in patient divided revascularization with IABP versus control and demonstrated no effect on 30-day all-cause mortality and 6-year long-term follow-up regarding the IABP. Then second ECLS shock trial was similar in extracorporeal life support in infarct-related cardiogenic shock, in which showed that 30-day all-cause mortality was not lower among patients who received early ECLS group with medical treatment versus usual medical treatment alone. So ECLS and IABP2 trial suggest no mortality benefit. Only danger shock trial is the only trial, first trial which demonstrates that early use of a microaxial flow pump in selected patients with STEMI-related shock randomized within 24 hours of cardiogenic shock at express center improved 180-day survival as compared with standard of care, noting an absolute mortality reduction of 12.7%. So, with microaxial flow pump may be considered appropriately selected STEMI cardiogenic shock patients with LV dominant shock who have evidence of clinical hypoperfusion and or hemodynamic deterioration. So these are the supporting device, right ventricular and left ventricular support device. Right ventricular support device, Impella RP Flex, RAP, right atrial pulmonary artery ventricular assist device, and a veno arterial ECMO which support the right ventricular. Veno arterial ECMO also support the left ventricle, so it help in biventricular failure. IABP, Impella CP and Impella 5.5 are the left ventricular support devices. So proposed treatment consideration for acute MI cardiogenic shock, in which stage B, in which hypoperfusion is establishing with lactate level hypoperfusion, means lactate level less than 2 millimole, and there is minor renal and hepatic dysfunction with hypotension, and patient is currently on no drugs or device. Then we have to find out whether LV dominant, RV dominant or biventricular failure is there. Then consider time-limited trial of vasoactive agents, and in stage B, role of temporary mechanical support device is uncertain. In stage C, if LV dominant failure cardiogenic shock is there, then we have to consider IABP or Impella CP. In RV dominant or biventricular failure cardiogenic shock, we have to consider Protect View or Centrimac device or Impella RP Flex with or without Impella CP or Impella 5.5. In stage D, patient is on currently treatment with 2 drugs or device. Then if LV dominant is present, then Impella CP, Impella 5.5 or veno-arterial ECMO with or without LV ventilation, assisted device is required. If RV dominant or biventricular, then we have to go for the ECMO with or without LV ventricular support device or Impella or Centrimac or Impella RP Flex which support the RV failure. In stage E, there is fulminant cardiogenic shock in which hypoperfusion is already established, and then we have to consider for the ECMO with or without LV ventricular assisted device.
એ જે સ્લાઇડ છે એ આન્સર છે કે ક્યારેક કઈ વસ્તુ
એક્ઝેક્ટલી જો આમાં આ જે ટેબલનું જે પેલું ડિસ્ક્રિપ્શન તમે વાંચો ને એમાં જે બી વાળી કેટેગરીમાં ટાઈમ લિમિટેડ ટ્રાયલ ઓફ વાઝોએક્ટિવ એજન્ટ લખ્યું ને એ ડિસ્ક્રિપ્શનમાં એ ટાઈમ લખ્યો હશે આ ફ્લો ચાર્ટનું ડિસ્ક્રિપ્શન રીડ કરજો એમાં રિઝનેબલ ટાઈમ કેટલો છે એ લખ્યું હશે.
The goal of temporary mechanical support device is to promote ventricular unloading as well as restore systemic perfusion and designed to bridge the CS patient to advanced therapy or facilitate myocardial recovery. The use of TMCS may allow de-escalation and weaning from pharmacological therapies that may exacerbate myocardial damage or ischemia if continued at high dose for the prolonged duration. This device selection depends upon the desiring level of cardiac index to improve the perfusion when pharmacological support alone is inadequate. When CS patient is under supported with respect to cardiac index on the present device, escalation may be warranted. If not adequately unloaded on present support, the range of therapeutic options include increasing the flow on current device or escalating the support device like Impella CP from Impella CP to Impella 5.5, addressing the afterload by means of LV venting or for veno-arterial ECMO and mitigating the congestion. So delay in initiation in mechanical support, circulatory support in appropriate candidate may lead to worsening end organ perfusion and derangement that ultimately culminate in multi-organ failure and death. Early CS recognition, prompt initiation and selective temporary mechanical circulatory support and serial reassessment may improve the outcome. In particular, the first 24-hour appear to be critical in the management of cardiogenic shock, as most patients with cardiogenic shock changes stages within the first 24 hours from the diagnosis, and stage B patients are at the highest risk of worsening shock severity by 24 hours. So in critical care management, there should be serial reassessment of indicator that may define the adequacy of hemodynamic support. So structured reassessment of patient with cardiogenic shock in ICU, clinical examination, vital sign clinical examination like mental status, perfusion, vascular access site, peripheral pulse, that should be measured every 6 to 8 hours. Perfusion of extremity and vascular access site should be examined every 1 to 2 hours. Vital sign like heart rate, mean arterial pressure and arterial oxygen should be measured continuously. Physiological like urine output should be measured hourly. Lab investigation like creatinine, bicarb, pH level, liver enzyme, lactate should be assessed 2 to 8 hourly depending upon the phase of care. Imaging like echo, X-ray should be echo will be required daily and chest X-ray as needed. Invasive monitoring require continuous measurement, and a shock team, interdisciplinary shock team require daily assessment of the patient. Then ventilation, positive pressure ventilation is necessary in the management of patient with cardiogenic shock, and it depends whether it decrease the RV and LV preload, decrease LV afterload and reduce LV compliance to the interventricular dependence. Now the hemodynamic effect of positive and expiratory pressure will vary depending upon how much preload dependence and LV contractility is present and whether RV failure is present or not. So potential indication for invasive mechanical ventilation in cardiogenic shock, in which patient has severe hypoxia, high work of breathing, clinical instability due to refractory shock, airway protection for invasive procedure, early intubation to decrease the myocardial oxygen consumption. If RV dominant shock is present, use of mechanical ventilation with caution only when necessary. Initial ventilatory strategy will be assist control mode with FiO2 starting from the 100% and rapid down titration to maintain the saturation more or equal 92%. Start the tidal volume with 6 to 8 ml per kg of ideal body weight, and then we have to adjust depending upon the PCO2 while maintaining plateau pressure less than 30 cm of H2O. And respiratory rate, start with the 10 to 20 breaths per minute and adjust to PCO2 level while monitoring for autopsy. If RV dominant shock is present, start peak with lower side 3 to 5 cm of H2O and use the lowest possible to achieve the O2 saturation more or equal 92%. And then we have to adjust the PEEP depending upon the PCO2 level and pulmonary capillary wedge pressure. If PCWP is 12 to 15 mmHg, then start the PEEP at 5 to 10 cm H2O. If it is elevated more than 15 mmHg, then PEEP can be increased to 8 to 10 cm H2O with monitoring of cardiac output, and we have to maintain the O2 saturation more or equal 92%. Then weaning of that mechanical circulatory support is element of integrated critical care management of patient with cardiogenic shock. Daily assessment of readiness to wean should include evaluation of hemodynamic stability, consideration of current total need for pharmacological vasoactive support, volume status, and whether the underlying cause of cardiogenic shock has been corrected or improved. Weaning includes a stepwise decrease in flow from the device, the pace of which will be dictated by the nature of initial cardiovascular insert and the reversibility. So readiness for deescalation daily is needed. बस weaning एक आज है बस पूर्ण
मैं समझ उसको
તમે બેઠા હોય તો સાંભળે ભાઈ એટલો ના
last initial evaluation last conclusion. So initial evaluation start. Recognize, rescue, optimize, stabilize, de-escalation or exit framework may serve as a useful heuristic. First phase of therapy is to recognize the cardiogenic shock and restore adequate tissue perfusion. Following this phase, goal is to tailor the pharmacological support to achieve hemodynamic stability with mean arterial pressure more than 60 mmHg. Stabilization phase characterized by recovery of end organ function and mitigation of extracardiac derangement, and then de-escalation or exit strategy depending upon the status of patient and whether require long durable assisted device or orthotropic heart transplant for appropriate candidate. So initial evaluation, then we have to risk stratification and stage classification we have to do, then initial management by vasoactive agent, then we have to address the congestion, respiratory support, then shock team activation, and then if necessary transfer to regional shock center. If primary pathology is myocardial ischemia, then we have to shift to the catheter laboratory. If an invasive hemodynamic may help to aid the decision regarding escalation or de-escalation of the therapy. So from time 0 to 60 minutes.
માં શક્ય બને કભી
એટલે
કભી लगता
मैं
है
आपने
पूरी
आडू
भगवान
છે ખાલી પીડું
कभी कभी लगता है पूरी भगवान
પ્રેક્ટિકલી પોસિબલ જ નથી આ 30 મિનિટ્સ ની અંદર તમે 10 મિનિટ ઇસીજી લો ઇકો લો
60 minutes they have suggested this is the golden 1 hour.
કેટલા વાગે
એ તો બરાબર